Hi, thank you for joining us for Responding to Domestic Violence. My name is Phoebe James and I am a Professional Development Officer with the Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the land we are all meeting on today and pay my respect to elders past, present and emerging. Just wanted to mention before we start that this session is being recorded. The recording and the PDF slides will become available on our PHN website in the Education Library in the next few days. We're having a Q&A session at the end of the presentation, so please feel free to put your questions in the box and we'll endeavour to get to all of them. We will have Shannon Richardson, who is a pilot program manager with the Primary Health Network, answering questions throughout. And if you have any follow-up questions about the program, please email Shannon and she will put her address in the chat box for everyone. Presenting today, we have Colette Hourigan, who is a women's health GP, and Alex Wilson, who is an accredited mental health social worker and clinical social worker with the Australian Association of Social Work. I will now hand over to Colette.
Thank you, Phoebe. And thank you to Alex for co-presenting and to Shannon and Phil for helping in the background. Now, welcome to everyone to today's webinar on this very important topic, domestic family abuse and violence. Now, you'll notice that there's a QR code there, and I was wondering if you could please scan it with your phone. There will be a pre-survey and a post-survey at the end, and it's really important that you complete this. Please do, because not only is it important for evaluation, but it's also important for funding services and ongoing education. Now, I'd like to, first of all, just let you know that we've taken a lot of care in preparing today's presentation, but we're aware that the content may trigger some people. There'll be people in the webinar today that may have had personal experience of domestic family abuse and violence. And I'd like to acknowledge your strengths for doing this webinar. Now, this webinar is not intended for specific legal advice. Now, I'd like to just explain that we're going to default to she for victim survivors and he for perpetrators. And this is purely because of the higher incidence in these demographics. While domestic and family violence and abuse does affect all genders, all age groups, it does occur outside of heterosexual relationships. But for today's talk, we're mainly talking about intimate partner violence in heterosexual relationships. So today's presentation is really just a brief overview, and there is a lot more training that you can have access to if you wish to. Now, we're going to also just have a look at what our learning objectives are for today as well. And so the learning objectives are really going to be to understand what domestic family abuse and violence is. We're going to look at how we spot the signs and then how we join the dots and start the conversation. And then how we go about linking our victim survivors for support, and also recording for safety. And Alex will be talking about this a little bit later in the presentation. Now, we're going to be looking now at what domestic family abuse and violence is. And we did have a video, but unfortunately it's not playing, but there is a link there if you'd like to have a look at it later. Now, domestic family abuse and violence, it's a systematic pattern of abusive behaviours designed to maintain power and control by one person over another person towards either their partner, a child, or a family member. The behaviour doesn't occur in isolation. It's not a one-off event or argument. It's a pattern of controlling behaviours that can cause incredible fear, feelings of helplessness, and also stripping away a person's sense of self and their identity. it can really impact on a patient's ability to trust their own judgment or to make decisions for themselves, or even know who they are and what their own values are. The experience of domestic family abuse and violence can be really debilitating, making victims actually dependent on the perpetrators by isolating them from all their support systems, such as friends and family, withholding access to resources such as money, education and support, or perpetrating technological abuse, monitoring their phone, putting trackers on, social media accounts, and monitoring who they're actually contacting, who they're ringing and who they're seeing. They can be in fear of physical or sexual violence for either themselves, their children, or their pets. And that is if the victim survivor doesn't play by the rules. They don't have a particular pattern of behaviour to please the perpetrator, then there's consequences. All of this can make it very, very hard for that victim survivor to leave that relationship. Now, it's important here to keep in mind that the concept of mutual abuse is not supported by evidence. There's a big difference between a victim physically, verbally lashing out or defending themselves in response to the abuse, and a deliberate and consistent pattern of behaviours aimed at controlling that other person. Now, the presence of two perpetrators in a relationship is often seen without considering that victim's resistance to the abuse. So if you're really struggling to work out who is the victim and who is the perpetrator, then it's a really good idea to refer to specialist family abuse and violence services very early on to have that established, because sometimes it isn't, that clear. Now, we have some statistics that will show you how prevalent it is. So since the age of 15, we know that 1 in 6 women and 1 in 16 men have experienced physical or sexual violence by a current or previous partner. 1 in 4 women and 1 in 6 men have experienced emotional abuse by a current or previous partner. And 1 in 5 women and 1 in 20 men have been sexually assaulted or threatened. So they're very high statistics. Now, in addition to that, in Australia, 8 women a day are hospitalised after being assaulted by a partner. 1 woman a week is actually killed by a current or former partner. And 1 in 6 children were physically and or sexually abused before the age of 15. So it's actually a really enormous problem that we're looking at. Now, there are some populations that are disproportionately affected by domestic family abuse and violence, and they can really struggle to access support. For example, those with language barriers, disabilities, culturally diverse groups, the elderly, and also Aboriginal and Torres Strait Islanders. Now, the New South Wales Health Strategy for Preventing and Responding to Domestic and Family Violence 2021 to 2026 places healthcare settings as pivotal agents in intervening with family violence. The healthcare system is often the first and preferred point of contact for victim survivors of intimate partner violence, and also for perpetrators when they want to seek support as well. So we're now just going to look at the effect of this burden of disease. So when you think about what the highest burden of disease is, what do you think the main cause is? What's the main contributing factor? Do you think it's domestic family abuse and violence, alcohol use, tobacco use, workplace hazards, being overweight or obese, illicit drug use, physical inactivity, childhood sexual abuse. So the answer to that is number one, domestic family abuse and violence. So intimate partner violence contributes to an estimated 5.1% of the burden of disease for women aged 18 to 44. And this includes the impact of illness, disability, and premature death. Now, the burden of family violence for Indigenous women in this age group, that is 18 to 44 years, is actually 6.3 times higher than for non-Indigenous women. Now we're going to just consider when a woman or victim survivor wishes to disclose that they're experiencing domestic family abuse and violence. So what do you think the highest and the second highest source of support sought by victims is? So the first source probably won't surprise you. And you can see here that a friend or family member is the most common. But then when we go to the second most common, it's actually their general practitioner. Patients are more likely to speak to a GP than they are to a police officer when seeking support for current family violence. Now, effective intervention approaches need to be embedded in a wide variety of community settings. For example, the healthcare system is often the first and preferred point of contact for victims of intimate partner violence and perpetrators when seeking assistance. So the New South Wales Health Strategy for Preventing and Responding to Domestic and Family Abuse and Violence 2021 to 2026 advocates for involving specialist family violence services and other agencies, as well as having easier pathways for not only us to navigate, but also for victim survivors to navigate, because we know it's been quite a difficult pathway to navigate up until now. But thankfully, with recent changes, it's become a lot easier. So we're now going to go into one of our other learning objectives, looking at how we actually spot the signs in both adults and children. Now, we're in a position where our patients or clients may bring up issues with us that they don't discuss with any other health professional. You might be the only person they disclose to. They may not have disclosed to their GP, but they may feel really comfortable with the person they're having counselling with, and they may disclose, first of all, to you. Now, guidelines suggest that once a disclosure is made, it's really important we explore that and how we look for clues. So let's look at, first of all, physical injuries. Now, the physical injuries may be things like genital injuries, musculoskeletal injuries, particularly if you see a patient with bruising at various stages of healing. That's often a sign that they're being repeatedly abused. The patient may report sexual assault, or they may have sexually transmitted infections. Chronic pain syndromes are very common in victims, such as, that headache that just can't be explained. They're not migraines. There's no underlying problem that anyone could put their finger on. So chronic pain syndromes. It may be chronic abdominal pain, chronic back pain, chronic headaches, chronic neck pain. And also we know that a very risky time for a woman to be experiencing abuse and violence is when she's pregnant, and it can really affect pregnancy and perinatal outcomes. and in terms of particularly miscarriage and stillbirth. Now, psychology may be depression and anxiety disorders, problems sleeping, problems concentrating. They may also be self-medicating by using substances, drugs, alcohol. They might present with eating disorders. They may present with suicidal ideation. They just don't want to live anymore. It's too hard. It's too overwhelming. Now, there are also emotional and behavioural indicators, such as feelings of irritability or anger, feeling really overwhelmed. They just can't cope. Hypervigilance, always on edge, always waiting for the next thing. Or behavioural cues, like missing appointments and not engaging in follow-up. Now, these things in particular can absolutely make our jobs difficult. So it's so much easier if we have a patient who always turns up on time and always follows our advice, but realistically, there's not many of those that exist. So, you know, we have to be prepared that this is a population where often they don't follow up. And what I tend to do is if they don't follow up, I ring them, I make sure I follow up, I rebook them in, I sort of give them a lot more leeway than what I would perhaps a patient not experiencing domestic family abuse and violence. So be aware of the presence of these risk factors and consider, is that patient safe to go home? You know, if there's anything else we can do, it's to actually keep our patients alive. And, you know, if she's really at any imminent risk of harm, we need to do something immediately. Now, let's look at the children. So 1 in 4 children are exposed to domestic family abuse and violence. An ANROS report investigating the mental health of children exposed to domestic and family violence found that children who had been exposed to this were 5 times more likely to have contact with the mental health service by the time they turned 18 compared to those who had no experience of family or domestic abuse or violence. So research also revealed that on average, there's a 6-year delay between police or health intervention for domestic family abuse and violence and a child receiving a mental health service, 6-year delay. So children and young people living at homes where there is domestic family abuse and violence are not just simply exposed to it, but they're actually experiencing it, they're living it. So some signs to be aware of are emotional distress, as the children may feel guilty, they may blame themselves for the violence. They may experience anxiety, depression, low self-esteem, trouble concentrating, you know, things falling behind at school. They may also get those somatoform chronic pain syndromes, such as headaches and abdominal pain. Once again, no underlying cause can be found. And also in adolescence, you know, self-harm is a real risk as well. Eating, sleeping disorders are common, and also the development of phobias and insomnia. Children, they may have trouble forming positive relationships, presenting less empathy and care for others. They may display aggressive behaviours towards others. As clinicians, it's important to hold curious, respectful, non-judgmental conversations about the impacts that the abuse is having on the children. So have these discussions with the parents. So you can then link both the parents and the children with early intervention support. As we know that abuse doesn't just go away. You know, we can't sit and hope it's going to get better. It's really important we do act early. So let's look at what you can do. So as we mentioned, linking for support early is really important, and that can be in the form of counselling, group programs for mothers and their children to, tend to rebuild that attachment that's been lost. It can be also speech pathology, because we know that these children are at much greater risk of problems with language development. And also it may be that they need occupational therapy for delayed milestones, delayed motor skills. And also we can increase protective factors. We can support schools to provide a trauma-informed response. We can link children with extracurricular activities that build confidence and contact with positive and safe adults, get good role models happening. Now, a 2022 ANROS report found that on average, children are not receiving a health intervention until 6 years after the first incidence of domestic family abuse and violence. So, domestic family abuse and violence, it's not cultural to First Nations. And these statistics do not represent more First Nations men as being perpetrators. So factors in the increased incidence include the impact of colonisation and intergenerational trauma. As clinicians, it's important to be aware of the current and historical events and structures that create the barriers to our First Nations people disclosing family, domestic abuse and violence. There's a fear of losing their children, a real threat of homelessness, language, cultural barriers, and also a lack of confidence in the police or community support. So Indigenous women may be unable or unwilling to fragment their identity by leaving the community, kin, family or partners. And because of these factors, First Nation people in Australia are 5 times more likely to be impacted by family violence than non-Indigenous. So earlier in the slide, that figure was over 6 times higher for women in that 18 to 44-year-old age group, but for all ages, it's actually 5 times higher, which is a really significant thing. With 3 in 5 Aboriginal and Torres Strait Islander women having experienced physical or sexual violence perpetrated by a male intimate partner and 11 times more likely to die due to assault than non-Indigenous women. So we need to create a safe space for our Indigenous women to disclose. So certainly in our waiting rooms, having First Nations art, having information about health promotion and educational materials can actually help them to access culturally relevant services and services that have Indigenous workers and programs. So just remember to follow the patient's lead. It's really important that we listen to our patients, we work with our patients. Now, the gold standard is to make a notification if we need to make a notification with our patient there, saying the words, "I'm making a notification in support of you." So many patients will fear disclosing because they think, oh, they're going to make a mandatory report, my children are being taken away from me. It's really important to know that you're there to help them. Any reports you make will be based on a strengths-based report in support of all the things that they've done to keep their children safe and all the services that they've engaged with. So it's important we list all the protective factors of the mother, including supports and willingness that she has shown to engage with those supports. So it's very important that we provide a safe space for disclosure. And I'm just going to hand over to Alex now, who will discuss that further. Thanks, Alex.
Thank you so much, Colette, and thank you everyone for having me. Okay, so yes, let's talk about a safe space for disclosure. So we need to ensure that we create a safe space for our patients to be able to disclose abuse to us. And we need to ensure that all of our staff, including reception and admin, understand the need for confidentiality. So this means not saying any personal or contact information within earshot of other people, ensuring the space is private. We do know that promotional items like flyers and posters encourage people to disclose. So you might want to think about including those things in your waiting areas. And again, we need to create this safe space for our patients to be able to disclose abuse to us safely. It's really important that we don't discuss domestic family violence and abuse if a child over the age of 2 or a partner is accompanying the patient, okay, for safety reasons. And you might also want to consider having policies that address the safety and well-being of your staff when working with these patients. Okay, so early intervention starts with a conversation. So after recognizing the risk or presence of domestic family violence and abuse, our next step is going to be starting the conversation with the patient. So we're going to talk about that now. And we're going to look at our case example of Angela. Okay, so Angela is 34 years old. She lives with her husband and her 2 children who are 2 and 5. Angela has come to see her GP as she is experiencing ongoing low mood, fatigue, poor concentration, and occasional sleep disturbance. There's no underlying physical cause that can be identified in your assessment so far, and you have reason to believe that domestic family violence and abuse may be presented here. So let's think about what might be the implications when starting a conversation with Angela. Okay, we're going to run through some possibilities here. So number 1, what could happen? Angela might be offended. Okay, so this is possible, and this is one of the main reasons that GPs and other people, professionals, don't ask about domestic and family violence and abuse. So there are many ways women may present to you. They could be fearful, angry, not ready to acknowledge the abuse. Remember, there's no right way to react to domestic and family violence. So every reaction is valid. The patient may not be ready to disclose. If clinical indicators are apparent, keep the door open and check in during future appointments. As Colette said, just keep that contact going so that you know that we can keep eyes on the situation and keep that communication happening. Okay, another possibility when we start a conversation with Angela is that she is relieved and talks about the violence. However, then you as the clinician is kind of left with this hot potato with possibly limited time and without support. So the good news here is that there is the local coordination point and the DFV local link. So we're going to be talking about those further on, but you have places to go in order to get support and advice and referral options for your patient, okay? Third possibility, you talk to Angela, you start the conversation, and she says there's no domestic and family violence, but she appreciates being asked. So we know that women actually want to be asked about this stuff. So again, follow the patient's lead, and if indicators are present, just keep the door open and check in, keep checking in during future appointments. Another possibility, finally, is that Angela says yes, that there is family violence going on, but she's not ready to leave. So it's really important not to feel frustrated by this, as it can take time for patients to be ready to leave. That's really normal. So women take up to 5 to 7 times to leave these situations, according to statistics. And the greatest risk of being murdered after separation, with 75% of domestic family violence related deaths occurring after separation has occurred. Okay, so it's a very risky time when women do leave. And some women will want to stay in the relationship, but they just want the violence to stop. Okay, so that's really normal. And again, we just want to offer that support and continue the conversation. So a conversation can save a life. So here are some 4 steps that you can use to start the conversation. And it's important to note that in our response, we're not expected to become specialists in family violence, okay? Our own fears can be a massive barrier to asking specific questions about domestic violence, but we inherently want to help our clients. And so if we feel ill-equipped to manage these clients, we don't want to get in the position of sort of ripping the Band-Aid off without having anything to redress that wound, okay? So this basic framework can help base our response to ensure that we use our limited time effectively and cover all the essential elements in the response, okay? So as primary healthcare providers, whatever that role looks like for you, we want to, first of all, ask the question. Yep, in a compassionate manner, stay open and curious. So questions like, how are things at home? Is there anything else happening that might be, affecting your health? What happens when your partner gets angry? I often like to ask, what does it look like when your partner gets angry? So that somebody can tell me the behaviors. Are they yelling? Are they throwing things? Are they hitting? What's happening? We might say sometimes partners use physical force. Is this happening to you? So we're being direct, but we're being compassionate and open in that first question. Then we're going to listen without judgment. So we want to listen to the person closely with empathy and without any hint of judgment there. So statements like, I hear you, I believe you, I care, I'm here for you, things like that sounds really stressful and difficult for you, just conveying that empathy. Third, we're going to validate their feelings. So we're going to show that we understand and believe them and assure them that they are not to blame. Yep, so statements like, I'm so sorry this has happened to you. Thank you for telling me. This is not your fault, things like that. And then finally, the 4th step is we're going to encourage some action. So we're going to support the person by helping them connect to information services and social supports. We can ask them if we can complete the action plan and link for support, which we're going to look at. So statements like, do you mind if I ask you some more questions to help keep you safe? Before you leave, I'd like to develop a safety plan with you. Is this okay? I'd like to link you with a specialist support service. Is that okay with you? Okay, so we're doing this with the patient, not to them. But yes, we're encouraging some sort of action be taken. Okay, so next, I'm going to introduce our domestic violence primary care action plan. Okay, so this action plan provides an easy to follow process to enable clinicians to identify patients at immediate risk, to plan, manage, record, and link for support to the local coordination point, okay, the LCP. So this action plan, you can upload it as a template into your practice software if you like to do that, and then you can actually send it as an electronic referral to your local coordination point. For allied health or other people that maybe don't have that practice software, there's also a PDF version. So this form, this plan is designed to be used collaboratively with the patient. So again, we're not doing this to them, we're doing this with them. We know that giving control back to these patients is really important, and this action plan doesn't have to be completed in one session in its entirety. You might, take some time to do it. So there are 3 pages. We've got the first page, which is client details. Okay, so this is sort of our minimal information about safe methods for contact, that sort of thing. Page 2 is our risk assessment, so screening for risk factors, assessing best response depending on the risk, and reviewing risk factors for change, okay? And then page 3 is the plan. So you can download this action plan on the PHN Domestic Family Violence website as well. So we don't have time to go through each of the 13 questions on the action plan today, but here's an example of the evidence that sits behind some of the questions that you'll find on the action plan. So there's a question around strangulation. So a victim is 7.5 times more likely to be murdered if their partner has tried to strangle them. Okay, so that's a red flag if that's coming up in our assessment. Coercive control is a significant predictor of homicide. So the New South Wales Domestic Violence Death Review team noted that in 99% of homicides it reviewed, the relationship was characterised by coercive and controlling behaviours. So a really important thing to screen for. Recent separation or planning to leave. So again, this is the most dangerous time for a woman and her children. So again, the New South Wales Domestic Violence Death Review team found that where a female had been murdered by a former partner, they had separated within 3 months of that homicide. So a very risky time, that 3-month period. And also threats to kill, including threats to kill pets and children. So big red flags with those things. Perpetrators who threaten to kill their partner or former partner, themselves or others, including their children, are particularly dangerous. Cruelty and harm directed at pets and other animals can indicate risk of future or more severe violence and are often used as control tactics by perpetrators. So again, just some red flags there that you'll find in that action plan risk assessment page. Okay, so safety planning. So a safety plan will assist patients to make decisions that will keep them and their children safe when they're dealing with an abusive situation. So it's important to consider a patient's short-term needs and long-term needs, their immediate safety and their children's safety. So safety at home, at work, and technological safety, including mobile devices and the internet, are all relevant there. Okay, and it's really vital that safety planning be conducted with the patient. Again, we're working with them, we're not doing things to them. And they will have the best idea of what will work and what won't for their situation, right? And it also increases the likelihood that the plans will be effective because they've been involved in them. So some things a patient might include in their safety plan are identifying family and friends who could help them if the threat of violence or abuse is present or escalates. Arranging a safe place where they could stay with their children if needed, again, if things escalate quickly. Keeping children safe. So where are places in the home that are safe? Maybe places that have locks on doors that could keep children safe. How could we prevent the user of violence from accessing private information from the victim? Yeah, are there measures we can put in place there? We want to decide with the patient when the police should be called and possibly alert neighbours about their concerns and ask neighbours to call the police if they hear a disturbance. Another great tip is preparing an escape bag and having somewhere safe to keep it. That could also have making sure they have access to cash, either in that bag or they have something where they can access cash, important documents, so passports, IDs, things like that. Making sure they have emergency numbers, arrangements for pets, things like that. Okay, so all really great things to put into a safety plan for someone who is not ready to leave right at this time, but may need that plan at very short notice. So how about things to avoid? Okay, so there's a few things to consider when supporting a patient affected by domestic family violence and abuse. So couples counselling and family therapy is not appropriate for situations of domestic family violence and abuse. So abuse is not a relationship problem. Yep, couples and family therapies typically assume an equal responsibility of problems, and this assumption can increase risk through exacerbating the imbalance of power further. Okay, so it can make things worse. The focus needs to be on the abuser making change. Yep. And additionally, couples and family therapy are not safe spaces for a patient to disclose abuse. Okay, because any disclosures that the abuser is aware of may increase their use of violence and abuse. So again, could make things worse. We also want to choose our language carefully. So when first seeing a patient or a client, a clinician might get enthusiastic and may want to dive into solution-focused approaches and goal settings. Okay, but if a patient or client is a victim affected by domestic family violence and abuse, that could actually be harmful. So we want to avoid asking questions like, what could you have done differently? These can be really harmful. These questions may unintentionally be placing the responsibility and blame onto the victim instead of the abuser. We don't want to focus on identifying and changing our patient or client behaviors, okay? These behaviors may be self-protective and provide resistance from the abuse. The person choosing the violence and the abuse needs to make the change, okay? And we want to follow our patient's lead here. So 40 to 45% of women killed by their spouses are separated or in the process of separating. So again, this is a very risky time. And don't expect your patient or client to leave the relationship quickly or ever, okay? That's not a requirement in order to provide them support and safety. So next we're gonna watch a little video called You Can't Ask That. Why didn't she just leave? All right, so have a watch. Might just take a minute. Thank you for your patience. Okay. So yeah, some really powerful lived experiences there. So let's have a look now into the third component, link for support. So we're going to let our clients take the lead with supports. Okay, so here we can see a whole list of supports. So for our clients, many of their choices may have been taken away. So again, it's really important to give the client their support options, but to empower them to make decisions themselves. So when you and your client have established what support they require, you can use that primary care action plan that we mentioned before, that I showed you before, as a referral document to your domestic family violence local link. Okay, that's that first little box right there. So the DFV local link provides specialist risk assessment, triage, crisis support, and referral. The service also provides advice and guidance to clinicians directly, which is awesome. So you can contact them if you've got questions or concerns about your role and what to do. So the DFV local link sit within the local coordination point or the Women's Domestic Violence Court Advocacy Service. And there are 6 local coordination points within the region. Okay, if it's after hours and your client would like immediate support, then you can consider a referral to the domestic violence line, which is listed there, 1-800-RESPECT or Men's Helpline. Okay, those are your after hours 24-hour options as well. Okay, so now let's look into the fourth component, recording for safety, a really important part of things. So keeping accurate records and keeping that information safe and secure is a critical part of managing risks to people's safety. Records that workers keep as part of their work practices, such as case notes and emails, are important in keeping the person who commits domestic and family violence in view. It documents clearly their patterns of behaviour and how it's impacting on the client and the family. This is especially important with domestic and family violence, as ongoing records can provide a record of a pattern of behaviour over time. And good record keeping also helps with collaborative interagency work and referrals. It's also an important way to support applications for things like intervention orders or breaches or other legal processes if required. And the safe storage of confidential information is essential in domestic family violence situations because unauthorized or inappropriate disclosures of information can have an extremely harmful consequence for a victim's safety and the safety of others. So, what should you write down? Documenting domestic family violence may feel uncomfortable, but it's really critical as it increases the safety for women and children. And it can also assist in identifying and monitoring risks over time. So it can help in identifying and providing evidence of cumulative harm and escalations. So we want to make sure that we make a note also if the perpetrator is present in the consult. And we don't write opinions, we can write direct quotes of what's said and factual information like that. We want to note all types of violence and abuse that's going on and dates and times where possible. Okay, we want to document well-being, so the impact that the violence might be having on the victim, so things like sleep disturbance, mood changes, weight changes, fear or anxiety. It's really important to put mental health or drug and alcohol issues within a context in our documentation. Victims may use alcohol or other drugs as a strategy to cope with overwhelming feelings and traumatic experiences like domestic and family violence. So it's really important in our documentation that we identify that in the context of the violence. It can also assist in facilitating appropriate referrals, ensuring that child protection reports are sufficiently detailed and accurate. Okay, we want to document reasons why you might identify your patient as the victim, and document the patient's assessment of their own safety and their children's safety, and of course any safety plans, and noting down any referrals that you make. Now, reporting and sharing information. So victims may be reluctant to have notes taken for a range of really valid reasons. So it's important to be open and honest with them about documentation, including confidentiality and its limits. So where possible, let them know what you are recording and why. Again, that it's actually in support of them. As clinicians, we're all aware of the importance of confidentiality, but we're also aware there are circumstances that require us to break that confidentiality. So if there are children present and there is domestic violence, even if the violence is not directed at the children, we're aware that we need to consider their safety. As mandatory reporters, we should use the online decision tree on the Child Story website. And that's going to guide us as to what we need to do next in terms of reporting. Consider registration on the Child Story Reporter website. You can submit e-reports after completing the decision tree, and then you will be sent an email to advise you of change of status of reports, and you can access the portal to view a history of past reports that you have made, which is really handy. So consider registering for that. It is important to remember that you are protected under Part 13A of the Crimes, Domestic and Personal Violence Act. A service provider can share information where there is domestic and family violence threat, and for the purpose of making a referral for domestic and family violence support services for a victim survivor, providing support services to a victim survivor, and preventing or lessening a serious threat to a person's life, health, or safety. And also, if we want to review Part 13A of the Crimes Act and the Chapter 16A of the Children and Young Persons Act, and if in doubt, contact the Child Protection Line for advice and guidance. Okay. There's also some further information to guide you through reporting and sharing obligations in the online toolkit, which will be released soon, and there's a link for you there in that last little box. Okay, so let's talk now about self-care. Working with people impacted by domestic and family violence can obviously be really challenging. Some may find that they experience vicarious trauma, burnout, compassion fatigue, or possibly are re-traumatized due to own experiences of domestic family violence and abuse. So it's really important as practitioners we engage in self-care and ensure that we have appropriate support to reduce the risk that this work will impact negatively on our own mental and physical health. So things you could consider are things like group supervision, individual supervision, sourcing external supervision is sometimes a great idea, and other support services for yourself. And remember, don't hesitate to contact your local link at the LCP for guidance with your patients. So they are there to help. So questions, support, all that sort of stuff, just give them a call. All right, so finally, the PHN is offering free training to practitioners who would like to learn more about domestic and family violence. You can head to the domestic family violence page on the PHN website to register your practice for training. For patient advice and support, again, you can contact your domestic family violence local link. That's relevant as well if you receive a subpoena for clinical notes. You can also contact them for advice about your responsibilities and also, limitations to releasing certain documentations, information that can be redacted, things like that. So they're a great source of information about all of that stuff. And again, if you could please, pretty please, take the time to complete the pre and post survey for the national evaluation. We would be so grateful. The more evidence that we can produce that speaks to the need and benefits of having free primary care training and a dedicated domestic family violence local link, the more chance we have that this pilot will be funded on an ongoing basis. All right, so I think we're going to go into some Q&A now. I will hand back to Phoebe.
Thank you. We haven't had any questions come through. We still do have a couple of minutes, so if you did have any questions, obviously this is a very heavy topic, so you might not want to ask questions in this forum, but please feel free to reach out to Shannon individually. I want to thank you all for coming, for taking the time out of your day. I wanted to thank our speakers, Colette, Alex, just fantastic presentation, really, really helpful, great information, very practical, which I think is important. A big shout out to Shannon for instigating this whole thing, and a big thank you to Philip, who has been the man behind the curtain today with the slides and presentations. So that's all from us. Thank you. Look after each other and stay safe.